Okay, Bismillah ar-Rahman ar-Rahim. Today we are talking about very important topics. It is under the umbrella of anesthesia and intensive care. We are talking about chronic pain management. And I have to say that this is just an overview regarding the physiology and management, because as you know, chronic pain management now regarded as a super specialty, and we have a fellowship for chronic pain management. And you can imagine that the student studying and practicing pain for 2 years, associated with the weekly lectures about the several topics under the chronic pain. So it is difficult to summarize all the chronic pain within single presentation, but here we are talking just an overview of chronic pain management. And in this overview, we will talk about peripheral receptor activation, what is called the transduction, pain transmission, modulation, and perception, types and characters of chronic pain, sites of activity of different analgesics, which drug work in different pain models, role and time of interventional pain management. And before proceeding with our topic today, you have seen now this statement: don't use your intelligence to show there is a problem. Use your intelligence to show there is a solution. Any comment about this statement?
مرحبا استاذ.
تفضل.
دائما استاذ خلي تفكيرك بالجانب الايجابي المنتج العملي، يعني وجه اتجاهك باتجاه طريق الحل وليس باتجاه ايجاد العوائق والمشاكل.
Very good, Bader. Very good. Any other comments regarding this statement?
أستاذ ممكن إنه هاي إحدى قواعد القيادة leadership، يعني حتى يعرف هذا الشخص إنه هو بالفعل قائد للمسألة، إنه لازم أن يبحث عن الحل وما يبحث عن المشكلة. يعني أكو 3 أنواع من القادة، إنه شخص إنه ممكن أن يقول لك راح ألقى حل، وأكو شخص يلقى الحل، وأكو شخص يلقى الحل ويخلص وبعدين يبلغك فيه، فيستخدم الانتليجنس اللي هو مقدرته أو ذكائه في إيجاد الحل.
Very good, Amir. Very good. Any other comments or ideas about this statement?
عفوا استاذ، ممكن مداخله عن الموضوع؟
تفضل.
هو هذا مقوله حلوه دائما يقولوها، يعني قبل ما تطرح المشكله اطرح لها حلول حتى تكون يعني عنصر فعال بالموضوع.
Yes. شكرا. All of you now focusing on the using our intelligence to show there is a solution, but unfortunately there are many persons always just show their intelligence regarding the showing the problems. They can talk a lot about problems, but they can talk very little about the solutions, because actually they are not thinking in the solution. The solutions is apart from their perspective. فشوفهم اكو بعض الناس دائما يعني يكونون جدا اقوياء في موضوع الانتقاد وفي موضوع تعديد المشاكل، لكن هو شو مقدم وشنو الحلول اللي مقدمها nearly null. النقطة المهمة أنه إحنا مو دائما نقدر نلقى حلول متكاملة، يعني مو دائما نلقى حلول متكاملة، بس ممكن إذا واحد according to his or her ability ممكن أن يلقي just 1, 2%, 3%, 5%. يعني المهم هو سوى اللي عليه، مو يعني يقول لا تلعن الظلام مو، ولكن اشعل شمعة. هاي الشمعة ما راح تنير كل الظلام، راح تنير فتح حيز جدا قليل، بس على الأقل أنت سويت اللي عليك. فدائما خلي يكون تفكيرنا منتج، أنه احنا مو بس نعدد المشاكل لكن في نفس الوقت نجد الحلول. 2، إذا حاول يعني بعض الأشخاص المجتهدين يجدون بعض الحلول، فاحنا مو دائما يعني نكون أقوياء في نقد الحلول على أنها جزئية، والكل يدري بيها جزئية، لكن حلول جزئية أفضل من لا حل. Regarding the definition of pain, this is an update at 2020 from the YASP, which is International Association of the Study of Pain, YASP. The old definition at 1979, which is the definition of pain, very solid definitions, stayed for 4 decades. And even at 2020, you will see that only small modulation of the words of this important definition. The 1979 definition, pain, unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in a term of such damage. At 2018, YASP continued a 14-member multinational task force with expertise in clinical and basic science related to pain and asked them to study the old definition and if this is the time to change some of its content. And the only change, just a modulation of this definition. This is the 1979 unpleasant sensory and emotional experience associated with actual or potential tissue damage. These words in green color are described in terms of such damage, replaced by these green color words, which is unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So as you see, only modification of the words rather than the genuine change of the definition. It is still very solid definition that contains many important principles related to pain. So from this or these two definitions, the pain is whatever the patient says. Patient say, I have a pain, we have to respect that he has a pain. Also, some can criticize this by the patient may lie or the patient may has a psychological problem, but we have no another tool to assess the pain. We can assess blood pressure and measure it by sphygmomanometer. We can measure pulse rate by several devices, but we have no device to measure the pain. So the pain is objective, is subjective rather than objective. And we have to depend on the patient feeling of pain. This is number one. And many people report pain in the absence of tissue damage or any likely pathophysiological cause. If they regard their experience as pain, it should be accepted as pain. Can you imagine the description of pain in the absence of tissue damage, but still regarded as a pain? For example, phantom limb pain. They have pain in the limb which is not there. If the pain is always associated with actual or potential tissue damage, then they should not feel pain on the limb where there is no tissue at all. So it described in the term of such damage according to first definition. So till 1960s, they were sent to psychiatrists thinking they must be mad. Now it is a well-established phenomenon with a clear pathophysiological explanation. So this is the idea beyond the acceptance of the description of pain from the patient, because some pathophysiological explanation may be hidden from our perspective. So in phantom limb pain and some other chronic pain, problems lie in the nerves, not in the damaged tissue. Now, what's the chronic pain? We have several definitions for the chronic pain. According to American Chronic Pain Association, the pain that continues a month or more beyond the usual recovery period. This is very beautiful definition. Really, I respect this definition and depend on its content within my daily practice of pain management. That when patient complaining of, for example, pneumonia, and the usual recovery period, for example, 2 weeks, if the pain continues month after these 2 weeks, then it is chronic pain. And if the patient has, for example, fracture of bone and the usual recovery period, I mean the recovery from pain, not complete union, maybe 1 week, and the continuation of pain after 1 month after this 1 week can be regarded as chronic pain. And other definitions, some has described chronic pain as a pain persistent more than 3 months. Why? Because they believe that by 3 months, pain itself become a disease rather than a symptom, because the original disease may be completely absent, but still the patient complaining of pain only. So the problem now is a pain rather than the original disease. And also others can define the chronic pain, that pain persistent more than 6 months. But actually, why I have said that the first definition more suitable and practical, because can you imagine if any person in your family is complaining of pain, and we say we have to wait 6 months to deal with it as a chronic pain, or we have to wait 3 months to deal with your patient as a chronic pain. It is not a practical, and the pain, very disaster feeling. Some person cannot tolerate pain for days rather than months. So it is difficult to deal with the pain as a chronic after 3 to 6 months. Now I'm telling you my experience regarding the complaint of patient and how we can interfere with that complaint. And you know that all pain is acute pain till it becomes chronic pain. Is pain an alarm? Is pain an alarm? For example, abdominal pain may by this abdominal pain we can discover appendicitis or cholecystitis. But is the pain an alarm always? Amal Yasin.
نعم أستاذ، السلام عليكم.
عليكم السلام.
الله يبارك. أستاذ يعني إحنا مرات إنه البين إذا كان في سايت معين يعني احتمال إنه ينطينا differential diagnosis عن فد شيء، بس يعني مرات إذا إنه حسب البيشنت إنه مرات مثلا يعني عندنا واحدة من الأشياء إنه مثلا هو إنه ما دا ينطي الشكوى الصحيح، أو إنه احتمال هو دا يقول عندي وجع بس هو ما عنده وجع يعني.
Okay, thank you.
Okay.
Thank you, thank you. True for acute pain. When there is acute pain in abdomen, by this pain we can discover appendicitis, cholecystitis, or other causes and deal with them. But when the pain becomes chronic pain, it is not alarm. Now it is a disease itself rather than the alarm. So there is a false idea that we have not to treat pain because this pain may represent original disease and we have to discover this disease. This is wrong. Chronic pain has very important complications and sequelae, and we have to deal with that pain, otherwise there will be more worse with the increasing the time without treatment. Form of acute and chronic pain can be physiologic, non-pathological, or pathological, which either nociceptive, somatic, nociceptive, visceral, neuropathic, and central. And we will talk about these types of pain in the next slides. The differences between acute and chronic pain, that acute pain mostly nociceptive, chronic pain mostly neuropathic. Acute pain, a symptom of a disease. Chronic pain, a disease itself, a disease of nervous system. The treatment of acute, in the acute pain, the treatment of a disease cures pain and it is self-limiting. While in chronic pain, difficult to treat this pain and sustaining. In acute pain, there is simple relationship between pain and tissue damage. While in chronic pain, dissociated relationship between pain and tissue damage. In acute pain, there is a this pain proportionate to the clinical finding, while chronic pain disproportionate to the clinical finding. There is area between neuropathic pain and nociceptive pain, which is mixed type of pain that contain signs, symptoms of neuropathic pain and nociceptive pain. And here, there are several examples of nociceptive pain: post-operative pain, mechanical low back pain, arthritis, sickle cell crisis, And in neuropathic pain, post-herpetic neuralgia, neuropathic low back pain, distal polyneuropathy, central post-stroke pain, trigeminal neuralgia, complex regional pain syndrome. And here the 3 types of pain, and under each title there is some examples. Regarding the chronic pain, it is either with ongoing tissue damage or without ongoing tissue damage. For example, patient with let's say CA anywhere, and develop pain. This pain with ongoing tissue damage, with the continuing of pain, still there is ongoing tissue damage due to CA. Patient with osteoarthritis of knee joint, this is a chronic pain with ongoing tissue damage because the damage is continued. While the chronic pain without ongoing tissue damage, for example, post-herpetic neuralgia, it is a chronic pain, but at the time being, there is no further tissue damage. The tissue damage already has happened in the earliest form of herpes zoster and stopped, and now the patient complaining of pain without ongoing tissue damage. In these 2 forms of chronic pain, the central sensitization is a constant feature, and we will talk about this important concept, central sensitization, later. This is simply the physiological pain when there is a brief injury here. This impulse transmitted to the central nervous system, and the central nervous system feel this noxious stimuli as a pain briefly. So brief noxious sensation that initiate alerting withdrawal responses limiting tissue injury. So there will be a reflex of withdrawal to decrease the effect of this stimulus. We have several types of nerve fibers, and here our attention towards 3 types from these fiber types. First one, within the A type, we have 4 subclasses. One of them, which is delta, transmit a pain. And the beta transmit touch and pressure. And we will talk about beta, how can be also take part in the feeling of pain. And also within the C fiber, there is a sensation of pain. So 2 types of fibers can transmit pain, which are A delta and C fiber. And we have 1 type, which is A beta, transmit touch and pressure. Regarding the touch and pressure, the low threshold A beta fiber, so there is innoxious sensation. Feeling of touch is not noxious, while the high intensity pain transmitted by A delta nociceptor lead to feeling of pain because this is high threshold fibers and sensation of pain. But sometimes with the advancement of a disease of a chronic pain, we will feel this low intensity touch pressure as a pain also. Nociceptive. The nociceptive caused by inflamed or damaged tissue activating nociceptors. And we have superficial somatic nociceptive, deep nociceptive, which divided into deep somatic and deep visceral. Regarding the somatic nociceptive, activation of nerve ending in somatic structures, skin, muscle, or bone in response to irritation or injury. Pain is persistent, well-localized, sharp, or crushing in this type, which is the somatic structures related to skin, muscle, bone. And this pain can be picked up during trauma, surgical pain, tumor invasion, arthritis, and muscle spasm. While the visceral nociceptive, activation of nerve ending in GIT tracts, peritoneum, in response to irritation or distension. The criteria of this pain is persistent, poorly localized, cramping, periodic, which is colicky. This included in bowel or urethral obstructions, peritonitis, and appendicitis. What about neuropathic pain? It is caused by damage, irritation, or injury to or malfunctioning of the nervous tissue. The neuropathic pain is usually continuous and shouting, and described as burning, electrical, stabbing, or tingling in a form of pins and needles. We have two neuropathic pains, peripheral or central. Peripheral originating in the peripheral nervous system, central originated in the brain and spinal cord. The mechanism of neuropathic pain, it is very complex and very different from nociceptive pain. The nociceptive pain, well understood and known for all, while the pathophysiology of the neuropathic pain is not so well known for all, and the differences can be accounted for the limited success of conventional analgesics in the treatment of neuropathic pain. When you treat the nociceptive pain by conventional analgesics, there will be a response for this analgesics, while the giving of analgesics for the neuropathic pain can produce only partial success. Major pathophysiological mechanisms related to neuropathic pain: peripheral sensitization, central sensitization, sympathetic activation, disinhibitions. These are four important mechanisms for the neuropathic pain, and we will talk about these important mechanisms. This is the neuropathic pain, and when the neuropathic pain persistent, there will be changes, and one of these changes that this is just a touch sensation, touch, and you know that a touch can be feel as not noxious feeling through the A-beta fibers, right? But with such sensitization, this fine touch of the skin can be felt as abnormal, severe pain. So there is aberrant and persistent noxious sensation associated with peripheral or central neural injuries. And this is very important and add more complexity regarding the understanding and management of the chronic pain. As you see here, both low threshold mechanoreceptor A beta and A delta and C fiber, these are already responsible about pain, but this is was just for the touch, but actually both of them now transmit all the stimuli, even the fine touch can be perceived as pain. So this is hyper-excitable dorsal horn neuron. The pain transmitted through a pathway, and you know very well that there are some differences between the tract that transmit pain and temperature from that transmit touch receptor. Both of them consist of 3 orders, but there are some differences already you have been taken in the presentation of neurophysiology last year. Pain perception serves 2 purposes. After the perception of pain, there are 2 important purposes. First, localizes the noxious stimulus and initiates withdrawal reflexes that minimize tissue injury. Second, initiates motivational and effective responses that affect future behaviors. But intense and prolonged pain transmission lead to changes in neural processing and connectivity that may result in a chronic pain. Here are the important nociception and pain processing till the perception, from the start of stimulus till the perceptions, and after that the response to that perception. The start by noxious stimulus, the process here, the step, we call it transduction, and after that the primary sensory neuron transmits pain through the peripheral nerves to the spinal cord, and in the spinal cord there is a modulation for the perception of these signals from the noxious stimulus. So transduction, conduction, modulation, and after this modulation there will be a transmission within the central nervous system from the spinal cord to the brain, and here in the brain there is a step of perception of that pain, and after that the CNS response, for example, that causes skeletal muscle spasm, neuroendocrine release, increased sympathetic overdrive. After the perception of pain and detection of the localization of that pain and detection of the severity of that pain. And according to these 6 steps, there are several medications and maneuvers used to manage pain according to the steps. For example, in the first step of transduction, we can get a benefit of non-steroidal, of antihistamine, topical local anesthetic, and in the conduction, can get a benefit from peripheral nerve block with local anesthetic, and in the transmission, We can get a benefit from epidural, spinal, with local anesthetic. And in the modulation, there is an effect for the opioid, clonidine, non-steroidal, and for perception, opioid, paracetamol, clonidine, ketamine, gabapentin, tricyclics, all can play a role to decrease that pain. And for the response, we can use a muscle relaxant or beta blocker, muscle relaxant or beta blocker. أحمد قيس.
نعم أستاذ.
أحمد قيس هنا يقول in the central nervous response we can use a muscle relaxant. Your opinion.
نعم أستاذ.
Your opinion أحمد.
والله ما أعرف أستاذ.
يعني نسوي له تيوب مثلا؟
أكيد لا يعني.
صحيح. ثانك يو أحمد. المقصود بهذا سنترال ماسل ريلاكسنت اللي هو احنا كلنا ماخذيه بس يجوز انتم ما حاسين، الموجود بالكانالجيسيك والمايوجيسيك والالجيسيكس واكو other types of medications used that contain several types of central muscle relaxant, and the famous one is the baclofen that acting by a mechanism of central muscle relaxation, and these type don't interfere with the skeletal muscle that lead to paralysis like that of depolarizing and non-depolarizing muscle relaxant. So we can use all of these types safely. Ali Munadal.
نعم أستاذ.
Also here mentioned the beta blockers.
يعني أستاذ هنا يسوي انهبيشن للبيتا ريسبتورز بالبريفرال اللي هي واحد يعني نير فايبر، أحد التايبس اوف نير فايبرز.
لا هي بالحقيقة نفس البيتا بلوكرز but can this you know the Indiral for example play a role in decreasing the tension and decreasing the tremor and decreasing the palpitations. All these regarded as responses for pain, and we can minimize them by beta blocker with the precaution regarding the negative effect of these drugs, like the effect of bradycardia, hypertension. We can study the advantage and disadvantage of the benefit of this beta blocker, and then to decide the use or not and with the which dose. Here the nociceptor, as you see, nociceptors defined as unmyelinated nerve endings found in skin, bone, and muscle and viscera. This is the nociceptor that from which the feeling of pain transmitted to the through the nerve to the spinal cord, and there are several mediators play a role in a transduction like bradykinin, prostaglandin, and the nociceptor activation initiate an inward calcium current generator potential which depolarizes sensory nerve fiber اللي هي A delta and C fiber. Here the calcium, and after that generating the action potential by sodium-potassium exchange. This is a slide just to show the complexity of the transduction of pain. There are several neurotransmitters and peptides, and several factors play a role to transduct pain and then transmit it through the peripheral nerve. And prostaglandin play a major role in the peripheral inflammation, and it is also responsible for nociceptor activation and sensitization, so regarded as a primary noxious mediator release from damaged tissue, and important factor play very important role in the transduction. Here, this is the dorsal horn and pain fiber projections to spinal cord. Here there are several zones named as laminae, and these laminae dealing with the signals come from the peripheral nerves and dealing with them in the modulation stage, the modulation of pain in the dorsal horn. And this is magnified picture regarding the dorsal horn. So here you can imagine the pathophysiological processes to deal with the pain, and how can this physiologically minimized by inhibitory interneurons, and this inhibitory interneurons will be abolished in the chronic pain, lead to exacerbation of the feeling of pain. Look the complexity and the take parting of several factors and peptides. Sensitization, very important term related to chronic pain, and it is a phenomenon of inappropriate or disappropriate response to normal stimulus, and can be divided or classified into peripheral and central sensitization. Within the sensitization, there is neural responses to tissue injury. We call it hyperalgesia. Hyperalgesia means exaggerated feeling of pain in response to normal painful stimuli. We have primary hyperalgesia and secondary hyperalgesia. In a primary hyperalgesia, there is increased pain sensitivity at the injury site, while in the secondary hyperalgesia, there is increased pain sensitivity at the adjacent uninjured sites also. This is due to sensitization. And in primary hyperalgesia, the primary hyperalgesia related to peripheral release of cellular or hormonal noxious mediators, while it is unrelated to changes in excitability of the spinal neurons. Peripheral sensitization is a sensitization of the primary afferent terminals. Active nociceptors become sensitized and the sleeping nociceptor awaken. There is also damaged axons, sprouts, forms, collaterals. احنا شلون عندنا بالفازلز مرات يصير collateral vessels in case of injury، هنا راح يصير collaterals of nerves. Also, in peripheral sensitization, there is ectopic discharges along nerve axon terminals and DRG, dorsal root ganglion. While actually, normally, no ectopic discharge. The discharge is begin at the receptor, nociceptor, and transmitted from nociceptor through the nerve. While here the discharge become ectopic and along the nerve axon terminally at the dorsal root ganglia. Anywhere can discharge the signals of pain. Also, the sympathetic nervous system fiber invade the DRG, and as you know, for example, in the muscles, bone, skin, fascia, all these are somatic, feeling and innervated, and apart from the autonomic sympathetic nervous system, but with the sensitization, peripheral or central, there will be involvement of sympathetic nervous system within these somatic structures, and also a phenotypic switch in expression of neuropeptide like substance P and CGRP. فإذا تلاحظون هنا بالperipheral sensitization، يعني احنا شلون بالعامية نقول عندنا برنامج وانضرب قام يخربط. يعني إذا تلاحظون يعني أول نقطة أنه راح يصير everywhere can be sensitized and give us signals everywhere، فيسموها ectopics. صار عندنا ectopics من أي مكان يجينا البين. 2 راح يصير عندنا collaterals. 3 راح يصير عندنا involvement of sympathetic nervous system. 4 many other important substances and peptides that take part within the process of pain feeling, increase and switch. So the feeling of pain will be exacerbated. And in the central sensitization that can occur in the central nervous system, in the spinal cord and the brain. So in the dorsal horn, the transmission, the signals lead to oncogenes, affect the oncogene to release C4s and C-Jun, and these are lead to stimulation of neuropeptides and nerve growth factor release that alter the pattern of nerve connections. C4's expression can be suppressed by opioid local anesthetic, Namda antagonist like ketamine, and alpha-2 agonist like clonidine. The central sensitization can involve the following principles. The central sensitization in which there is central reorganization, and also what is called wind up. There is summation of signals rather than the feeling of separate signals, and in which there is upregulation of Namda receptor. This leads to exacerbated, exaggerated pain feeling. And also there is ectopic activity, and there is depression in the inhibitory synapses and activation of يسموها wide diameter fiber range. So wide diameter range of fiber. In the central reorganization, long continued stimulation lead to central reorganization, that in which a beta fiber develops connection in lamina 2, lead to allodynia. الأمير عواد.
أستاذ اسمعك.
الأمير عواد, beta fiber develop connection in lamina 2 lead to allodynia. What does it mean, allodynia?
I don't know.
Okay, Amir. Allodynia means the feeling of non-painful stimulus like touch, for example, felt as a pain. يعني واحد تسوي له touch هو شيء يحسه يحس بالبين، هذا يسموه الودينيا. فهنا شلون صارت هاي الالودينيا؟ شنو اللي صار؟ احنا ليش قلنا ري اورجانيزيشن؟ التاتش ينقله عاده البيتا، الاي بيتا فايبر. هاي الاي بيتا فايبر تسوي كونكشن ان ذا لامينا 2 اللي هي مسؤوله عن البين فايبر، فلذلك انت راح تحس بس هو بالحقيقه تاتش. زين. عندنا area of pain increases along other nerve distribution. يعني الاريا اوف بين ما راح نحسه بس بمكان البين، وانما راح نحسه in other area supplied by the same nerve distribution. Loss descending inhibitory pathway. مجموع هاي الامور راح تسوي لنا reorganization اللي هو one important principle of central sensitization. Another principle of central sensitization, activation of Namda receptors, acute pain, lead to AMPA receptor, dislodgement of magnesium from NMDA receptor, lead to activation of Namda receptor. Activation of Namda receptor causes increased signal transmission and release of nitrate and substance P and prostaglandins. All these lead to increase the perception of pain. And the net result of central sensitization, net result, increase intensity of pain. يعني pain هو بسيط نحسه قوي. Increase area of pain. مثلا pain هو in single finger نحسه بكل الابرمنت. Increase duration of pain. مكان ما يتعالج ب7 أيام راح نحسه ب7 أشهر. Decrease tolerability to pain. يعني بعد ما تحمل البين. Development of psychological problems. Pain become non-responsive to conventional analgesics. أنا أريد من عندكم شوية تتأملون بهاي 6 important points تتأملون بيها. To realize the complexity and the difficulty of managing a patient complaining of pain. Okay, so our job in the chronic pain is so sophisticated, and it is not a matter of يعني جزء بعض الناس يقول يحسن النية يعني بينا يقول يا معود هسه أنا أوديك للدكتور الفلاني يشتغل بالكرونيك بين مانجمنت بس يضربك أوبرس تصير زين. It is not like such. It is more difficult because of all these factors or the results from the central and peripheral sensitization. You cannot realize the effect of a psychological problem. احنا يعني طريقتنا بالعاده يعني بحياتنا نقول هذا لما نقول هنا عند psychological problem يعني نتصور الموضوع هو emotional. It is not only emotional. There are structural changes lead to psychological problems. So it is difficult to manage. And also the tolerability to pain different, the area of that pain is expanded, the duration increased. فلذلك احنا نعلم المرضى انه البين هذا اللي هو chronic pain و difficult pain و patient suffering from pain نقول له يعني هذا نحسبه in percentage ما نحسبه it is either all or none. لو اكو pain لو ماكو pain. This is wrong. واهم شيء انت يعني اهم the most important role to correct the wrong concept that the patient has. يعني من يجي البيشنت ويقول لك دكتور يعني يروح كل الالم، اول نقطه تحطم هاي القاعده. تقول له انت متأذي من الالم؟ يقول لك ايه. تقول له الالم شديد؟ يقول لك ايه. تقول له زين اذا هذا الالم نصه راح شنو شعورك؟ يقول لك ابوس ايدك. شوف هسه هنا تحطم فد important principle عنده راح، فراح يكون التعامل وياه اسهل. فراح نتعامل وياه على اساس البرسنتج. برسنتج يعني انه انت البين مالتك هسه 100%، راح نشتغل وتجينا برا 10 ايام تقول لنا النيو برسنتج اذا كانت 50 75 25. ممكن نسوي لك other sessions، ممكن نسوي modification of management. فنقول له انت ايش قد صار لك تتألم؟ يعني انا واحده البارحه جتني تقول لي صار لي 8 سنين بوست هيربيتيك نيورالجيا. فهاي صار لها 8 سنين تعاني، جتني يعني تريد يعني اني بجلسه واحده مثلا ارجعها يعني complete free of pain. This is unreasonable due to these factors. من نحكي وياها بهاي الطريقه وتتقبل، ذاك الوقت يعني يبدي التعامل وياها اسهل. فاحنا شو نقولها؟ نقولها انت صار لك ايش قد عندك الم؟ تقول 8 سنوات. اقولها وانا شو وقت شفتك؟ تقول هسه جيتك. فاقولها اعطيني مجال، يعني انت صار لك 8 سنوات تتاذين، اعطيني give me a chance to manage your pain. give me a chance. فلذلك الموضوع احيانا يحتاج sessions، يحتاج dealing with the psychological changes، لانه هاي psychological changes انا اعتبرها ال first barrier that can refuse even refusing the management of pain. هسه تقولون شلون كان refusing the management of pain؟ راح احكي لكم اياها بالعاميه حتى تفتهموها. يعني وحده مره خلينا نقول old age عمرها 50 60، وهاي عندها pain severe pain عندها هاي المرة. فنشوف احنا هاي المرة اوكي، فنشوف هاي المرة يعني consulted several doctors without any result for months or years. فهنا يجوها هواية ناس خيرك شبيك عندي ألم قوي. هذا الألم القوي ليش ما تروحين الطبيب؟ رحت لهواية أطباء وما عالجوني. الألم مالتي غير قابل للعلاج، الألم مالتي غير قابل للعلاج. يا معودة اكو ألم غير قابل للعلاج يحتاج تروحين هذا اكو طبيب الفلاني كل الزين روحي له وهسه تصيرين زين. فهنا باللاوعي دخلت بمنافسة about her opinion انه ألمها غير قابل للعلاج، وجدتي وحده تقولها لا ماكو ألم غير قابل للعلاج. فهنا هسه شو تريد يروح الألم لو تريد تربح المنازلة مع هاي المرة اللي قالت لها انت ألمك قابل للعلاج؟ إذا تعالجت لربما تشعر انه هي طلعت كذابة. فهنا المشكلة الرئيسية اللي يعني psychologically maybe interfere with the management of pain. يعني can you imagine لما الموضوع يصير سنوات وياه اللي يجي تقول له ألمي غير قابل للعلاج، ألمي غير قابل للعلاج. فهاي تقوم تجيك اسقاط فرض حتى تضيفك للقائمه مالتها. خاف واحد يقول انت ما رحت الدكتور اياد عباس، حتى تقول له ايه هم رحت الدكتور اياد عباس وهم ما صار الزين. ف in my experience, I have to interfere with this important objection, essential objection of the relieving of pain at first, by dealing with the patient from a new perspective of view. مثلا اول شيء تطمئنها تقولها والله انت صحيح المك كلش قوي والمك كل الصعب يتعالج، وحقهم حتى الاطباء اللي رحتي لهم وما صرت زينه حقهم لان موضوعك كل صعب. بس اكو هسه صار تطور جديد يعني بالعلاج مال الالم وكذا، فاكو بعض الامور اذا نسويها يعني احتمال تتعالجين، فبس يراد يعني انه تعاون وياك. فهنا انت ما طلعتها كاذبه، تقولها انت حقك وانت صادقه، وفي نفس الوقت انت بديت وياها بدايه قد تكون يعني مفتاح، يعني window for the new chance to manage this patient. I stopped on this slide too much due to the importance of this slide, and my aim that all of you realize the content of this slide, لأنه even in your social life you may face such a patient, and to deal with them according to these steps. يعني يمكن واحد من عندكم مو يقول للمريض بعد أود تروح لفلان طبيب ويروح الألم، وإنما ممكن يقول له أنت شغلتك يراد لها سيشنز، يراد لها مراحل، يتعامل وياه على هذا psychological factor. and ممكن يعني any one of you can produce a help to some of his or her relatives. Reactions to the pain. Somatic motor reactions ممكن يصير عندهم spasm. Autonomic reactions ممكن يصير tachycardia, increase blood pressure. Emotional and psychological reactions يصيرون disappointing, depressed, and sometimes psychologically upset. Symptom of chronic pain, pain in the area of neurodeficit, allodynia, and we have defined the allodynia, and the hyperalgesia means the exaggerated feeling of pain in response to normal painful stimuli. Character of pain may be burning, shooting, electric shock, like, or stabbing pain. And there's associated symptom like numbness, tingling, pruritus, feeling of pin and needles. Association of sympathetic nervous system lead to redness, color, edema, painful joint movement, decreased skin temperature, and fall of hairs. Problems of chronic pain, central sensitization, altered anatomy and physiology of pain processing pathway, decreased pain threshold, associated depression due to decreased serotonin level, existence of different pain cycles, which are very difficult to be break. These are some examples of chronic pain: cancer pain, neck pain with or without upper limb and or headache, low back pain with or without lower limb pain, neuralgia like trigeminal neuralgia, joint pain, chronic post-operative. I think you have seen this slide. It is one table from the study has been done by Perkins and published in Anesthesiology. And in this study, mentioning one type of chronic pain, which is the post-operative pain related to several types of operation, and you can see the high result, high incidence related to several types of surgery. You can see that the thoracotomy associated with chronic pain about 30 to 67, and in limb amputation up to 83%, and in hernia, which is a simple surgery and regarded as moderate surgery in severity, the incidence may be up to 37%. And we are facing all these types of chronic pain in our daily pain management clinic. All these types can be seen. The treatment of pain better to be in multimodal approach and can be interventional pain management, using of combination of analgesics, using of adjuvant therapy, using of physiotherapy, using of consultation of psychiatrists. Unfortunately, there is poor collaboration with the psychiatrists in our country for several reasons beyond the scope of this presentation. And for the medications used, acetaminophen, NSAID, antidepressants, anticonvulsants, antispasmodics, corticosteroids, local anesthetics, alpha-2 adrenergic agonist, Namda receptor antagonist, and opioids. This is the repeated slide that several types of medications and maneuvers according to the state of the transmission and feeling of pain. Treatment of acute pain can be using NSAID for very short period, paracetamol in adequate doses, tramadol, Zaid, paracetamol in adequate doses, or regional anesthesia, analgesia. Treatment of chronic pain, if the chronic pain with ongoing tissue damage, we have to stop the nociceptive input if we can. For example, patient with knee osteoarthritis, we can stop the tissue damage by total knee replacement, for example. But sometimes if the tissue damage due to, for example, CA, difficult to stop nociceptive input. The second step, correcting neuropathy and central sensitization. Yeah, that is to say, even after total knee replacement, due to chronic pain, sequelae, still we need to deal with neuropathy and central sensitization. And if the pain without tissue damage, like post-herpetic neuralgia, ما عندنا هنا nociceptive input to be stopped, so directly towards collecting the neuropathy and central sensitization. In case of chronic pain without tissue damage, the treatment of peripheral sensitization can be by sodium channel blocker or calcium channel blocker. And we will talk about the drugs under these important groups. Treatment of central sensitization, Namda antagonists, calcium channel blockers, opioid drugs, inhibiting substance P, drugs enhances inhibitory synapses. Restoration of descending inhibitory pathway via tramadol and a tricyclic antidepressant. So in general, anti-neuropathic medication can be either through interventional options or systemic analgesics. The opioid analgesics efficacy is unclear, effective in higher doses compared to those required for nociceptive pain. Concurrent use of a drug like gabapentin may provide better analgesia with lower doses. Anticonvulsant traditionally used for neuropathic pain, for example, carbamazepine and phenytoin, but the newer agents, which are gabapentin, pregabalin, lamotrigine, are more commonly used in the management of neuropathic pain at the time being. Anticonvulsant. Different drugs produce their analgesic effects by different mechanisms. For example, blockade of calcium channels, gabapentin and pregabalin. Blockage of voltage-dependent sodium channel like carbamazepine and phenytoin. Actions on glutamine secretion, lamotrigine. Older anticonvulsant like carbamazepine, phenytoin have significant adverse effects, making them poor candidate for the first line of the therapy at the time being. However, in trigeminal neuralgia, carbamazepine, stronger evidence, or oxycarbamazepine, better tolerability, should be offered as a first line in the management. So nowadays, the tegretol carbamazepine used may be only in the trigeminal neuralgia as a first line of management. Previously, was used with phenytoin in most of the neuropathic pain. But after the development of gabapentin and pregabalin, the use of these two drugs decreased much in many types and diseases related to neuropathic pain, and only in trigeminal neuralgia, carbamazepine is still used as a first line of the management. Gabapentin, the mechanism of action increases concentration of GABA, attaches to alpha delta subunit of calcium channel, doses 300 milligram per day at bedtime, increased by 300 milligram per day every 3 to 5 days, and the range of the management 900 to 3600 per day. So it is called wide therapeutic range. wide therapeutic range. ممكن تعطيه من ال 300 واكو حتى ابو ال 100 نستخدمه للاولد ايج، من ال 100 الى 3600 safely. فلذلك يسموه wide therapeutic range. الادفيرس افكت somnolence, dizziness, ataxia, fatigue, GIT disturbance, and nystagmus. Pregabalin, it is a GABA analog. Mechanism of action increases GABA concentration in the brain, increase in glutamic acid decarboxylase activity, also wide therapeutic range starting from 75 to 600, and also there is a dose of 25 available. Adverse effect, dizziness, somnolence, headache. Lamotrigine, mechanism of action, blocks voltage-dependent sodium channel, inhibits glutamate release from presynaptic channels, modulate calcium and potassium channels, dosage 25 milligram bed, increase at 25 milligram per week, maintenance at 300 to 400 milligram per day. Adverse effect, dizziness, nausea, headache, ataxia, diplopia, blurred vision, rash, rarely syndrome called Stevens-Johnson syndrome, which is related to rash and blisters in the skin. And this is drug associated with significant drug-drug interaction. Antidepressant, also traditionally used for the neuropathic pain, tricyclic antidepressant may be most effective classes of a drug. Amitriptyline, disipramine, not effective in HIV-related neuropathies. These are the types of antidepressant: reuptake inhibitors, receptor blockers, and enzyme inhibitors. We mainly use the drugs under these groups. Tricyclic antidepressant. From this group, there are two important subclassifications, اللي هي noradrenaline tricyclic antidepressant, disipramine, and serotonin tricyclic antidepressant, clomipramine. And from this, there is serotonin selective reuptake inhibitors. And within this group, there is important drugs in red color. Duloxetine can be used safely in most cases associated with neuropathic pain. These are several antidepressant drugs with their doses and mechanism of action. In general, the mechanism of action: inhibition of reuptake of noradrenaline and serotonin. Other pharmacologic mechanisms: monoamine modulation, interaction with the opioids, Namda, histamine, and cholinergic receptor. Clinical applications: presence of norepinephrine activity is often associated with better analgesic activity. Antidepressant with a 5-HT over noradrenaline ratio of less than 1 include amitriptyline, imipramine, doxepin, nortriptyline, and disipramine. While other group antidepressant with a ratio of 5-HT over noradrenaline more than 1 are venlafaxine and fluoxetine. So this group better in the management of pain due to increase the ratio of noradrenaline than this one. Selective serotonin reuptake inhibitors, weak antinociceptive effect, enhanced by opioid receptor agonist, lack anticholinergic, antihistamine, and alpha blocking effect of the tricyclic, no orthostasis, sedation, or cardiac toxicity, superior safety profile, اللي هي fluoxetine and sertraline and paroxetine. Now, the local anesthetics, lidocaine and mexiletine, are equivalent to morphine, gabapentin, and tricyclic antidepressant, can be used IV up to 5 mg per kg over 3 to 4 hours. Mexiletine 1 to 200 mg 3 times per day, up to 675 mg reported. Lidocaine 5% transdermal also effective. اللي يهمنا هنا نقطتين. النقطة الأولى, the using of lidocaine IV in the resistant cases that cannot be managed by other alternative analgesics and interventions. We can use lidocaine infusion in sessions and the dose about 5 mg per kg for about 3 to 4 hours, and every 2 weeks, for example, and play important role to manage the neuropathic pain. And also we have lidocaine, transdermal patches can be applied on the affected area to decrease the neuropathic pain. Other drugs used, alpha-2 adrenergic receptor agonist, clonidine, NMDA receptor antagonist, tramadol, and capsaicin. هنا إذا تلاحظون الكلونيدين ما نستخدمه لأنه associated with the hypotension and severe dizziness. النمدا اللي for example الكتامين نستخدمه بس بالresistant cases لأنه associated with psychological side effect. Tramadol نستخدمه only in severe cases. And the capsaicin unfortunately unavailable and costly, and it is just the content from the red pepper, الفلفل الحار. كنا نحكي in this area اللي هي use of non-pharmacological and pharmacological medications to manage the pain, and if we fail to manage pain previously, there will be the surgical option. But in between there is a gap. This gap can be filled by interventional pain management. Interventional pain management, which means some minimally invasive procedures which gives permanent or long-term pain relief by stopping nociceptive input or correcting neuropathy. It fills the gap between pharmacologic management of pain and more invasive operative procedures اللي هي السيرجيكال. فإذا تلاحظون أنه أولاً which give permanent or long-term pain relief. ثانياً by stopping nociceptive, stopping or correcting neuropathy. Interventional options ممكن تشمل كل البريفرال نيرف بلوك، neuroaxial nerve blocks, sympathetic nerve blocks, intrathecal infusion. These are drug delivery system can be implanted within the body and release medications continuously and in low doses. And the spinal cord stimulation, which is a device implanted in the epidural space, consists of several electrodes, up to 12 electrodes, that interfere with the normal frequency of the signals of pain. فراح تسوي لنا masking for these frequencies and lead to unfeeling of the pain. This is spinal cord stimulation, and nowadays there is a trend to add peripheral nerve stimulation. What is the neurolysis? It is a procedure by which nerve fiber carrying nociception is destroyed to obtain long-term pain relief. This is the benefit of neurolysis. احنا لما ننطي local anesthetic ما نسوي destruction، نسوي blockade, temporal blockade. While in neurolysis هنا راح نعطي drugs causing destruction of the nerve fiber lead to long-term pain relief rather than the temporal relief. Why neurolysis? First, neuropathic pain, difficult to be managed. Cost effectiveness, health infrastructure, equipmental cost, all these will be cost effectiveness. Side effects of polypharmacy. Most of those patients taking several types of medications. Advantages of a neurolytic block: long duration of pain relief, inexpensive, repeated visit to pain clinic or hospital is not required, prolonged hospital stay is not required, patient can remain at home pain-free even where the medical help is scarce. Methods of neurolysis using the neurolytic agent like phenol, alcohol, hypertonic saline, glycerine, butamabine, ammonium sulfate, and chlorocresol. Actually, we are using at the time being phenol and alcohol. Other methods by cryoneurolysis, radiofrequency ablation. Cryo by using the freezing, and radiofrequency by using heating. This is the type of radiofrequency device. Common intervention for the treatment of patients with cancer pain, celiac plexus block for patients with upper abdominal pain or abdominal pain, splanchnic nerve block, the same indication of celiac, superior hypogastric plexus block for patients with pelvic pain, impar ganglion block for patients with perineal pain, stellate ganglion block for patients with head or upper limb chronic pain, brachial plexus for upper limb, lumbar sympathetic for lower limb. Each one of these blocks deserves a separate lecture. But here, as I already introduced, that this is an overview, just to give you an overview idea to realize the size of this branch, the chronic pain management. Interventions for low back pain, transforaminal epidural and perineural injection, caudal injection, interlaminar epidural injection, intradiscal injection using ozone, laser, decompression, coblation, medial branch block for patients with facet joint, intra-articular facet injection, sarcoiliac joint injection, piriformis muscle injections. And we have also advanced intervention, percutaneous discectomy by using laser, decompression, coblation, epiduroscope, using the epidural scope through the caudal foramen, and vertebroplasty by using a needle to inject a cement inside the body of vertebrae already collapsed due to either CA or osteoporosis that producing severe pain. After injection of the cement through a needle, the most of pain relief and the vertebrae becomes more stabilized. Intrathecal drug delivery system and spinal cord stimulators. These regarded as advanced intervention. Most of the interventions using either neuroscope or ultrasound. Most of the interventions done under the guidance of fluoroscopy or the ultrasound, and for the using of ozone therapy can be used intra-articular for knee joint, intra-articular for shoulder joint with or without supraspinal nerve block, intradiscal in patient with disc prolapse. This is the ozone generator, very simple device connected with the oxygen, and using from the oxygen generate the ozone, and here the input of oxygen and here the output of the ozone. Look, this is the input of oxygen, electric device, and this is the first device used in the medical city at 2009. These interventions should be done under complete aseptic technique. In summary, multimodal approach is necessary for chronic pain. Interventional pain management works in most situations where all other options has failed. Combination analgesic therapy, especially tramadol and paracetamol, is very useful and ideal combination in treating moderate to severe chronic pain. Adjuvant therapy is necessary in most cases. Physiotherapy and rehabilitation is essential too. Interventional pain management is the choice before surgical intervention unless there is contraindications. Thank you very much. If there is any question or comment.
السلام عليكم.
عليكم السلام.
مرحبا عماني، معاذ من السليمانية. عندي سؤالين الله يسلمك عني. عندي سؤالين، الأول بالنسبة للكرونيك يوز اوف بيتا بلوكر يسوي انديوس هايبر الجيسيا. السؤال الأول. السؤال الثاني عمي، مرات من نعطي سباينال أحس المريض عنده ألودونيا، يعني من نسوي له بريشر، من نسوي له بالارتري تيست ما يحس بالبين، بس يحس بالبريشر يصير عنده بين. فبس اريد اعرف هو اصلا عنده كرونيك الودونيا لو هو عنده اكيوت الودونيا، هاي مفاهيمها. شكرا جزيلا.
عفوا، هاي بالنسبه للسباينال هو مو الودينيا هاي، وانما هو يعني احنا قلنا له راح نعطيك تخدير نصفي فما تحس، فهو من يحس بالاصبع بالتاج يقول اذا هذا يعني فيلد سباينال، فيحتاج انه احنا انفورم ذا بيشنت لما نسوي سباينال انه انت ما راح تحس بالالم بس تحس بالاصابع وتحس باللمس بالتاج، فبهيك حاله بعد ما راح يخاف. الالودينيا هي feeling of pain in response to non-painful stimuli. هو ما دا يحس هنا pain، بس لان هو يعني اختلطت عند الامور احنا قايلين له راح نسوي لك تخدير ما تحس وهو دا يحس، فيتصور نفسه راح يحس البين هم فيبدي يخاف. فمجرد تقول له انه انت ما راح تحس بالبين بس تحس بالتاج ما راح تصير عندك هاي الحاله. بالنسبه للبروبرانول قلت يسوي هايبر الجيسيا، لا ما يسوي هايبر الجيسيا او البيتا بلوك.
شكرا جزيلا.
عفوا استاذ عندي سؤال. النيورولايسيس يعني يصير ريفرسبلي لو ممكن ريفرسبل يعني، لانه كاتب لونج ديوريشن ما كاتب يعني انه permanently.
Actually most of neurolysis last about 6 months plus minus، يعني يسوي destruction برا 6 months ممكن يرجع لك المريض يقول لك رجع عندي الألم، فتسوي له another neurolysis. مرات بعض البيشنت يجوز أكثر يروح سنة ما يجيك، أكو بعض الحالات 3 أشهر ويجيك. وبالنسبة للثيرمال يعني neurolysis by thermal radio frequency may last more than 6 months or 1 year, may last up to 2 years.
نعم استاذ.
But all of them, generally speaking, temporal, regarded as temporal, but 1 to 2 years.
شكرا استاذ.
العفو استاذ، بس حبيت انا دكتور احمد قيس، العفو بس حبيت اسال على الليمب امبيوتيشن، الفانتوم ليمب، هل يعتبر هو يعني كرونيك بين وذ تيشو دامج؟ لو هو هاي التيشو دامج راح خلاص بعد؟
without tissue damage.
تمام، شكرا استاذ.
Any other questions, comments? Okay, إذا ماكو, thank you very much and have a nice Friday. Goodbye.
شديدك استاذ.